Welcome to the deep dive. Today we're tackling canine hypoadrenocorticism.
Right. Addison's disease. That's what most people call it.
Exactly. And this is really your express route to understanding a condition that can, well, seriously affect our dogs. We've looked through the clinical papers, the general info,
Yeah, trying to boil it down.
to really pull out the essential knowledge you need. So you're here to get a solid understanding quickly, and that's what we're aiming for.
Precisely. Cut through the, let's say, the medical jargon and give you a clear picture of what Addison's in dogs actually is.
Okay.
What causes it, how you might spot it, how vets diagnose it, and what the treatment looks like.
Perfect. So let's get straight into it. What is Addison's disease in dogs, fundamentally?
Yeah.
And are some dogs more likely to get it?
Well, put simply, it's an endocrine disorder. So it involves hormones, specifically from the adrenal glands.
Right.
With Addison's, these glands, they just aren't making enough of certain vital hormones, mainly cortisol and sometimes another one called aldosterone.
So it's like the body's stress response and maybe fluid balance systems are running low.
That's a pretty good analogy, yeah. Cortisol is key for stress response, and aldosterone handles salt and water balance.
Got it.
And it's something we see, fairly often in dogs, but interestingly, it's quite rare in cats.
Oh, okay. Any particular age group?
Typically, it hits young to middle-aged dogs, but honestly, it can pop up at almost any age. And there's no real bias towards males or females.
No, I thought I read somewhere about specific breeds being more at risk.
You did, and yet that's where it gets quite interesting for owners of certain breeds. There is a higher predisposition in some.
That cool.
Standard poodles are a classic example. Also, Portuguese water dogs and bearded collies. Those pop up frequently in the literature.
Huh. So not every standard poodle will get it, obviously, but it's something for owners and vets to just keep on the radar.
Exactly that. Just raises the index of suspicion.
Okay, so we know what it is generally and who might be more susceptible. Let's dig a bit deeper now. Why does it happen? What's the underlying mechanism?
Right, the pathophysiology. There are actually a few different ways Addison's can develop.
Right.
The most common is what we call primary hypoadrenocorticism. Often this is immune-mediated.
Meaning the dog's own immune system?
Yeah, exactly.
Yeah.
The immune system mistakenly attacks and, well, destroys parts of the adrenal cortex, the outer layer of the gland.
Oh, wow.
And because it damages the whole cortex, or most of it, you get deficiencies in both glucocorticoids, like cortisol, and mineralocorticoids, like aldosterone.
So the body's defenses kind of go rogue and hit the hormone factory, leading to a shortage of both key types.
That's a great way to put it. Then there's atypical hypoadrenocorticism.
Atypical. How is that different?
In these cases, you only get a cortisol deficiency. Aldosterone production is usually fine.
So sodium and potassium levels might be normal?
Exactly. It seems the damage is limited just to the specific zone in the adrenal cortex that makes cortisol, the zona fasciculata.
Interesting distinction. Are there others?
Yep. There's secondary hypoadrenocorticism.
Yeah.
This one doesn't start with the adrenals themselves, but higher up in the pituitary gland.
The one in the brain.
That's the one. The pituitary makes a hormone called ACTH, which tells the adrenal glands, hey, make cortisol.
Right.
If the pituitary isn't sending out enough ACTH, then the adrenals don't get the signal, and again, you only get a cortisol deficiency. Aldosterone isn't usually affected because its release is controlled differently.
Okay, so pituitary problem leads to low cortisol. Makes sense. And wasn't there one related to, like, medications?
Yes, absolutely. That's iatrogenic hypoadrenocorticism. Iatrogenic just means caused by medical treatment.
How does that happen?
Two main ways. One is if a dog's been on steroid medications like prednisone for a long time, and then you stop them suddenly. The dog's own adrenal glands have gotten lazy because the medication was doing the work. They need time to wake up again. Stop too fast, and boom, not enough cortisol.
Like a system shock.
Kind of. And the other way is sometimes during treatment for the opposite condition, Cushing's disease, where the dog makes too much cortisol. If the treatment is a bit too effective, it can suppress adrenal function too much, potentially triggering an Addison's-like state.
Wow. Okay. So multiple paths leading to similar hormone deficiencies. Given all that, how does it actually look? What signs would an owner see?
Yeah, the clinical signs can be, well, they vary a lot. That's part of the challenge. We usually talk about two main ways it presents.
Sure.
An acute presentation, that's the Addisonian crisis, and then a more chronic, sort of long-term presentation.
Addisonian crisis. That sounds bad.
It is. It's a genuine medical emergency.
Mm.
A dog in crisis might be incredibly weak, lethargic, maybe even collapsed. They could be in shock because their blood volume is low. Often severe vomiting, diarrhea, no appetite at all. Sometimes, initially, they might drink and pee a lot, but that quickly progresses to severe dehydration.
Okay, so crisis, get to the vet immediately, no question.
Absolutely. Time is critical.
What about the chronic form? Is that easier to spot?
You'd think so, but not always. The chronic signs are often really vague, and they tend to wax and wane.
Wax and wane, like come and go.
Exactly. So maybe the dog has bouts of tummy upset vomiting, diarrhea that seem to resolve on their own, or they're just generally a bit weak, low energy, maybe losing weight slowly. A key thing owners might notice is that the symptoms seem to get worse during stressful times, like going to the groomer or boarding, or even just having visitors over.
Because their body can't produce that extra cortisol needed for stress.
Precisely. So those subtle, intermittent signs, they can be really easy to miss or mistake for something else.
Which definitely makes diagnosis tricky. So what are the clues in like blood tests and things that really point a vet towards Addison's?
Right, observation is one thing, but the lab work is crucial. There are several findings that act as red flags.
Okay, like what?
On a standard blood count or hematology, you might see mild anemia, but it's usually non-regenerative, meaning the body isn't actively trying to replace the red cells. But maybe more telling is what you don't see. You often don't see the typical stress leukogram.
Stress leukogram.
Yeah, normally when a dog is sick or stressed, certain white blood cells like neutrophils go up and others like lymphocytes and eosinophils go down.
Okay.
But in Addison's, because there's no cortisol surge, you don't see that pattern. Sometimes the lymphocytes and eosinophils might even be normal or slightly high, which is really unusual for a sick dog.
Wow, so the lack of a typical stress response in the blood is actually a clue itself. That's counterintuitive.
It really is. Then you look at the biochemistry panel.
What might show up there?
You might see signs of kidney stress, what we call pre-renal azotemia, basically increased BUN and creatinine.
Because of dehydration and poor blood flow.
Exactly. Also, maybe low protein levels, specifically albumin, sometimes low cholesterol, occasionally low blood sugar, and sometimes weirdly high calcium levels.
A lot of potential changes. But I feel like electrolytes are the big one I hear about.
They absolutely are. This is often the key indicator. We're looking for hyponatremia that's low sodium,
Right.
typically below about 140 millimoles per liter. And hyperkalemia, high potassium, usually over 5.6 or so.
Low sodium, high potassium.
Yes, but critically, it's the ratio between them, the sodium to potassium or NAB plus K plus O ratio.
Ah, okay. What's the magic number there?
A ratio below 25 to 1 is highly suggestive, and often in really classic cases, it's even lower, like below 15 to 1. That ratio is a major, major red flag for Addison's.
Wow. Okay, so NA plus K plus ratio 25, maybe 15. That's a key takeaway. Anything else in the initial workup?
Your analysis can help too, because aldosterone is often low. The kidneys can't conserve sodium properly.
So they pee it out.
Essentially, yes. And this means they can't concentrate their urine effectively. So you often find a low urine-specific gravity, usually less than 1.030.
Okay, so lots of clues building up, but these aren't proof positive on their own, right? Is there a definitive test?
Correct. These findings raise strong suspicion, but the gold standard, the test that confirms Addison's, is the ACTH stimulation test.
Okay, how does that work?
It's pretty straightforward. First, you take a blood sample to measure the dog's baseline cortisol level.
Right.
Then, you give the dog an injection of synthetic ACTH, that's the hormone from the pituitary we talked about, the one that tells the adrenals to make cortisol.
Gotcha.
And then usually about an hour later, you take a second blood sample and measure the cortisol again.
And what tells you it's Addison's?
In a healthy dog, that ACTH injection should cause a big jump in cortisol levels. The adrenal glands respond.
Makes sense.
But in a dog with Addison's, the adrenal glands are damaged or not getting the signal properly, so they can't respond. Both the baseline cortisol and the post-ACTH cortisol levels will be very low. Typically, both will be less than 5 nanomoles per liter, or sometimes stated as less than 2 micrograms per deciliter, depending on the lab's units. Essentially, there's no significant rise.
So flatline response, that sounds pretty clear-cut.
It usually is, yes. It confirms the adrenal glands aren't capable of producing cortisol adequately.
But you mentioned earlier that low sodium, high potassium, that low Na plus K plus ratio isn't only seen in Addison's.
That's a really critical point, you're right. While it's a classic sign, other conditions can cause similar electrolyte imbalances.
Like what? Just so people are aware.
Well, severe whipworm infections can sometimes mimic it. Also, acute kidney injury, certain kinds of fluid buildup in the chest or abdomen effusions, and sometimes very severe gastrointestinal disease.
Okay, so the ratio is a huge clue, but you still need that ACTH stim test to be sure it's actually Addison's and not one of these other things.
Exactly. It rules Addison's in or out definitively.
All right, so we've found the problem, we've confirmed it. What happens next? Let's talk treatment. First, that scary Addisonian crisis. How do you manage that?
Okay, crisis management. Priority number 1 is stabilization. That means aggressive intravenous fluids, STAT.
What kind of fluids does it matter?
Usually something like 0.9% saline, sometimes lactated ringers. The goal is to restore blood volume and blood pressure and help flush out that excess potassium. If the sodium is dangerously low, we have to bring it up carefully and slowly, not too fast, to avoid brain complications.
Right. Slow correction in the potassium.
We monitor it closely. The fluids help lower it, but if it's causing dangerous changes on the ECG, the heart rhythm,
Okay.
we might give intravenous calcium gluconate. That doesn't lower the potassium itself, but it protects the heart from its effects. We also watch their acid-base balance. Usually fluids fix any acidosis, but sometimes careful use of bicarbonate might be needed if it's severe.
And then you need to replace the missing hormones, right?
Right.
Urgently.
Absolutely. That's step 2. We need to give glucocorticoids immediately. Usually in an injectable form like dexamethasone sodium phosphate or maybe hydrocortisone.
Why those?
Dexamethasone is good because it doesn't interfere with the ACTH stimulation test results if you need to do the test urgently. Hydrocortisone replaces both glucocorticoid and some mineralocorticoid activity.
And the mineralocorticoid, the aldosterone replacement.
Yes, that needs starting too, especially if the electrolytes are severely off. We often give an injection of something called DOCP desoxycorticosterone puvalate or start oral fludrocortisone.
DOCP, that sounds like a mouthful.
It is. Most people just say DOCP. It's a long-acting injectable mineralocorticoid.
Okay, so fluids, electrolytes, hormone replacement. That gets them through the crisis. What about once they're, out of the woods? What's the long-term plan?
Right. Maintenance therapy. Once the dog is stable, eating, drinking, we switch to long-term management, usually at home.
How does that work?
For the mineralocorticoid replacement, the aldosterone part, we've got 2 main options people use. There's fludrocortisone acetate. That's a tablet, usually given once or twice a day. We start at a dose based on weight and then adjust it based on regular electrolyte checks.
So frequent blood tests initially.
Definitely. The other option is that DOCP injection we mentioned.
The long-acting one.
Yeah. It's given as an injection, usually under the skin, about once a month. The standard starting interval is every 25 days.
Once a month sounds more convenient than daily pills, maybe.
It can be for some owners, yes. But again, you need regular electrolyte monitoring, typically checking just before the next dose is due. Based on those results, we adjust the interval between injections.
So you might stretch it out longer than 25 days.
Exactly. If the electrolytes are stable, maybe push it to 26, 27, up to maybe 30 days for some dogs. If the potassium starts creeping up or sodium dropping, you shorten the interval back again.
Okay, so DOCP or fludrocortisone for the mineralocorticoids. What about the cortisol replacement long term?
For that, we usually use oral prednisolone or prednisone, typically given once or twice a day. The goal is to use the lowest effective dose that controls clinical signs without causing side effects of too much steroid.
So finding that balance.
Yes. Cortisone acetate is another less common option. But here's a really, really crucial point for owners.
What's that?
During times of stress illness, surgery, travel, even intense excitement, dogs with Addison's can't naturally increase their cortisol production like healthy dogs do.
Ah, right.
So their owners must temporarily increase the dose of their glucocorticoid medication, usually doubling or even tripling it for a short period based on vet advice.
That sounds vital, so owners need to be prepared for that.
Absolutely vital. Forgetting the stress dose can lead to problems, even potentially another crisis.
So it's clear that managing Addison's isn't just give a pill and forget. There's a lot of monitoring involved.
Oh, for sure.
Yeah.
Especially initially. In the hospital during a crisis, it's intense. Vitals every few hours, electrolytes multiple times a day, ECG monitoring.
Right.
Once they go home, the monitoring frequency decreases, but it never stops. Typically, we check electrolytes weekly for the first few weeks until they're stable on their maintenance doses.
Weekly at first. Okay.
Then maybe monthly for a bit. Once things are looking good and stable, long-term checks are usually needed every 3 to 4 months, sometimes 6 months, for very stable dogs. But regular checkups are key.
Makes sense. Consistent monitoring for a lifelong condition. So, with all this, diagnosis, treatment, monitoring. What's the overall outlook for a dog diagnosed with Addison's? What's the prognosis?
It's actually really good. The prognosis for dogs with hypoadrenocorticism is generally excellent.
Oh, that's great to hear.
Yeah, provided it's diagnosed reasonably early, and provided they receive consistent lifelong treatment and monitoring.
So commitment from the owner is key.
It's absolutely essential. But with that commitment, these dogs can live long, happy, pretty normal lives. The regular monitoring allows vets to fine-tune the medication doses over time and catch any potential issues before they become serious.
That is really encouraging. So let's just quickly recap our deep dive. Addison's in dogs. Adrenal glands not making enough cortisol and often aldosterone.
Right. Insufficient hormone production.
Signs can be dramatic, like a sudden collapse of the crisis, or much sneakier, like waxing and waning tummy troubles and lethargy.
Varied presentation.
Diagnosis hinges on those blood tests, especially the electrolyte imbalances, that low Na plus K plus ratio, and crucially, the ACTH stimulation test for confirmation.
Yep, specific diagnostics are key.
And the really good news is that treatment works. It requires lifelong medication, both mineralocorticoids like DOCP or fludrocortisone and glucocorticoids like prednisolone, plus that vital stress dosing.
Don't forget the stress dosing.
And regular vet checkups and blood tests. But with all that, the outlook is excellent.
Exactly right. Recognizing the signs, working closely with your vet, that partnership is crucial for a good outcome. Early diagnosis, consistent treatment, that's the recipe for success.
This has been incredibly helpful, thank you. It really drives home how finely tuned these hormonal systems are, doesn't it?
It really does.
How a deficiency in these, tiny amounts of chemical messengers produced by these small glands can have such profound effects on the entire body's function. It makes you appreciate that incredible internal balance.
The whole endocrine system is fascinatingly complex and interconnected.
Yeah. Maybe that's something for you, the listener, to think about that intricate dance of hormones constantly happening inside and how vital maintaining that equilibrium really is for health.
Something to ponder after our deep dive today. Thanks for joining us.